And we've managed to combine our Jack Crawford meeting with Grand Rounds this morning, and it's a pleasure to have Dr. Clark present to our Grand Rounds audience as well prior to the Jack Crawford Day. So once again, congratulations to the team at Sick Kids for what looks like a wonderful program. And I'll hand it over to Dr. Chung to do the official introduction for Dr. Clark. Thank you.
Thank you for the kind introduction, dear Amandeep. So good morning, everyone. Thank you for joining us today at our UofT Grand Rounds. It gives me great pleasure to introduce our distinguished international speaker, Dr. Robert Clark. So Dr. Clark graduated from Stanford University with a dual degree in biological sciences and electrical engineering, and he continued his medical degree at Stanford University. He then completed his ophthalmology residency and pediatric ophthalmology fellowship at the Jules Stein Eye Institute at UCLA. He is an assistant clinical professor at the Stein Eye Institute and currently in private practice in Long Beach, California. He has received an honor award from the AAO and also a senior honor award from the APOS committee. He is a renowned publisher with over 70 peer-reviewed publications and a full-length book. He's also a pioneer for new strabismus surgical techniques in posterior pulley fixation and equatorial myopexy. His primary research focus include orbital anatomy, strabismus, eye movement disorders, and myopia control. So please welcome our distinguished speaker, Dr. Clark, who will be presenting about normal and abnormal biomechanics of extraocular muscles. Take it away. Thank you.
Well, thanks to the program committee for inviting me, and thanks to all of you guys for showing up. 7:30 Friday morning. I do appreciate the effort over here. Now, I'm going to cover quite a bit of technical information. Don't get bogged down in the details. The details will change over time as our techniques improve. Think about the concepts, and the concepts will be enduring. For disclosures, I received grant support from the National Institute of Research Finance for these projects. I've also consulted with Cooper Vision and Bioluma on unrelated projects. I do want to acknowledge and thank my many collaborators over the years, especially Dr. Joseph Deemer. Now, Dr. Deemer and I started working together almost 30 years ago when I was a second-year resident at Stein Eye Institute, and we've continued on. He's been my mentor and colleague for the past 30 years or so. And I consider him one of the finest minds, most innovative thinkers in all of visual sciences. The goal of this talk is to give you important details about the orbital anatomy that will impact your clinical care of patients. I'm going to talk about normal and abnormal muscle pulley locations, normal and abnormal extraocular muscle compartment contraction, and also go over the most common cause of adult strabismus that we know of today. Now, some of the concepts I'll discuss today are considered controversial. For example, in the latest Basic and Clinical Sciences book put out by the American Academy of Ophthalmology on oculoplastics, the section on orbital anatomy includes descriptions of connective tissue that supports the globe and extraocular muscles, and even says this connective tissue can be entrapped and cause a muscle entrapment, even though the muscle is not entrapped. But the authors cannot quite bring themselves to say the word pulleys. Okay. Our publications about how the globe does not rotate about its center, or how the arc of contact does not have any clinical relevance, have been met with very strong opposition letters to the editor and criticism from prominent visual scientists. I think that a lot of these criticisms fall into kind of three basic categories. First of all, some of our research contradicts core beliefs in ophthalmology. Core beliefs are never easy to change, even in the face of overwhelming evidence. Second, a lot of our concepts increase the complexity of biomechanics. A lot of clinicians like to rely on simple rules of thumb. Rules of thumb work for many patients, but do not work for many other patients, which is why our results are so inconsistent. Finally, many of our studies have small numbers of subjects. MRI studies, histology studies are quite time-consuming and expensive, so it's hard to generate large numbers of subjects. To paraphrase my colleague and former editor-chief of Journal of APOS, Sherman Eisenberg, reviewers like large N's and small p's. P-values are the statistical probability that an outcome will occur. For example, will a medication lower eye pressure over a placebo? The laws of mechanics, though, are not subject to simple probabilities. And the laws of mechanics actually govern a lot of the extraocular muscles. Now, to paraphrase the X-Files, The data is out there. If you guys will approach this material with an open mind, look at the evidence with fresh eyes, I think you'll find most of it pretty compelling. Now, the first concept I want to talk about does the globe rotate about its center? Now, mechanically, this makes a lot of sense. It simplifies the mechanics quite a bit over here. If the eye rotates about its center, the lever arm is just the radius of the globe. And the lever arms for all the muscles are equal. And because they're equal, they cancel each other out. And basically, the only thing that governs eye position is innervation of the muscles. Now, this is a series of axial MRI scans of a normal subject in right and left gaze. The images have been superimposed to overlay all the bony structures. Now, looking at this image without any mathematical analysis, statistical analysis stuff, can you say with any degree of certainty, does the globe rotate about its center? Any takers? Well, the plus sign should give it away. So if you look at it over here, if the right eye, for example, when it goes from right gaze to left gaze, the center of the globe moves forward and medially by about a little over 1 millimeter. The left eye, as it goes from right gaze to left gaze, moves posteriorly and laterally by about 1 millimeter. Because the globe moves, its center cannot be the center of rotation. Eye movement is actually a combination of rotation and translation. Now, we published these results. Immediately, a prominent visual scientist who's very well known in orbital mechanics disputed our findings. Now, once again, you can actually see the findings without any mathematical analysis yourself. But he says that basically the movement was too small to be important, that our analysis was flawed. We actually had our numbers checked by a mathematics PhD, and he did refine our analysis here, but the core findings were the same. And finally, got to a small number of subjects. Now, I'm not a statistician, but if you find the globe rotates and translates in 19 consecutive normal subjects, what is the probability that this is a incidental finding? Once again, we found the only 19 people in the world where the eye actually rotates and translates. Now, without getting too much into the physics, torque is force times the lever arm times the sine of the angle of application. In prior classical modeling of eye movements, you think about the lever arm as just being the radius of the globe from point A to point B. And if you go through the arc of contact as having perfect tangency, the sine of 90 degrees is basically 1. So basically, torque would just be force times the radius of the globe. Very simple. But the center of the eye is not the rotational axis. It's actually an adduction displaced medially by about 1 millimeter or so, and anteriorly by about 1 millimeter or so. So it makes it much closer to the medial rectus and further from the lateral rectus over here. Plus the sine of the angle of application is no longer 90 degrees. So you can see that it does modify mechanical behavior. Now, these 19 subjects we analyzed here, the rotational axis was consistently anterior to the center of the globe. And this makes sense because there's a lot more resistance to rotation in the back half of the globe from all the connective tissue than the anterior half of the globe. Now, the interesting thing about it is the position of the rotational center actually shifts during eye movements. It's about 1 millimeter lateral to the center of the globe during abduction and about 1 millimeter medial to the center of the globe during adduction. So herein lies the beauty of the ocular motor system. In abduction, because the center of rotation is close to the lateral rectus, the medial rectus lever arm is actually longer and the lateral rectus lever arm is actually shorter. So a smaller amount of force when the medial rectus applied would rotate the globe back to the middle. In adduction, the lateral rectus has a longer lever arm, and medial rectus has shorter lever arm. And so basically a small amount of force restores the eye to the straight ahead position. So basically the system is designed to restore equilibrium with less force. Now, it's possible to measure the size of the lever arm in different kind of mechanical movements here. So in the slide over here, black is for abduction. This gray is for adduction, and the stripes is for convergence. So during abduction, the medial rectus has a longer lever arm, the lateral rectus has a shorter lever arm. In adduction, the lateral rectus lever arm is almost 50% larger than the medial rectus lever arm, and then in convergence, the similar account, the lateral rectus has a longer lever arm. Now, a few people would argue that a 50% increase in leverage would be a small, insignificant amount here. And this, to me, explains one of the mysteries of extraocular movements. The resting position of the globe is the balance of all the muscle forces. So how can a relatively flimsy lateral rectus completely balance a much beefier medial rectus? The answer is leverage. If it has more leverage, it's easier for it to balance the forces. So the resting position of the eye is a balance of all the different forces. The next concept I'm going to talk to is the arc of contact. It's got a recurring theme over here. The arc of contact simplifies mechanical modeling. The muscle is modified as being infinitely thin. And so when it wraps around the globe, as long as it maintains tension with the globe, the angle of force application is 90 degrees. Perfect tangent, 100% of the force is applied to the globe. But you all know that the tendon is not infinitely thin. It's actually relatively thick, especially for some muscles here. At the end of the day, if you model the behavior, the figure on your left over here shows what it's supposed to happen. The figure on your right shows what actually happens. There's a departure angle because of the thickness of the tendon. When you get behind the equator of the globe, this is the portion of eye movement where the lever arm is supposed to actually have the most effect. The arc of contact has the most effect over here. The muscle itself actually bows inward. And so you have a reduction in the loss of the arc of contact. So in the part of the eye where it's supposed to be normal, perfect force application, it's not perfect force. In the part where it's supposed to be abnormal, you have a reduction in the loss of force. So it really does not model what's happening in the actual eye socket. Now, this is a series of MRI scans in normal subjects. They've never had any surgery in different gaze positions. The only muscle which really maintains a good arc of contact is actually the superior rectus muscle. And up gaze pretty much maintains perfect tendency here. All of the other muscles have a departure angle from the globe, which is not a perfect arc of contact in just normal degrees of vergence here. Now, where this plays a major role is in trying to model posterior fixation. This figure here is from Dr. Alan Scott's classic description of the mechanics of posterior fixation. From the mechanics here, if you have the original muscle insertion and you actually create a posterior insertion with a scleral suture, as the eye rotates that suture past the equator of the globe here, the lever arm is supposed to be reduced as the eye continues to contract. Now, as you guys know, the eye does not rotate about its globe center over here. It turns out that the lever arm is also not as reduced as much as predicted. This is a series of coronal axial MRI scans before and after posterior fixation of the medial rectus. So in central gaze, here's the suture, and you can see that there is some loss of the arc of contact just based on straight ahead position. This is similar to what you'd find in adduction in normal orbit. But as the eye rotates into adduction further, instead of maintaining an increase in the loss of arc contact, the muscle actually bows inward and actually allows it to have a better arc of contact than predicted. What's causing this inward bow of the muscle? It turns out this suture actually collides with the anterior portion of the muscle pulley sleeve. It compresses the sleeve, and that compression bows the muscle inward. And this is a child here. These are intraoperative photos. The child has esotropia with a high AC over A ratio. The planned procedure is a medial rectus recession with posterior fixation. Now, in the top photo, where the surgery has been done, you see slightly esotropic under anesthesia. And if you do a forced duction into adduction, the forced duction is entirely free, as you'd expect for somebody who's esotropic. Immediately after placement of the posterior fixation sutures, there's a large restriction, rated as a moderate restriction. You cannot push the eye into adduction. And what happened? Well, this is a series of CT scans. The top series is before posterior fixation. The bottom is after posterior fixation. This is in a cadaver orbit. We've actually placed a metal suture needle through the medial rectus insertion and also another metal suture to the anterior portion of the medial rectus pulley sleeve. We have a lever mechanism, and when you trigger the lever before posterior fixation, the insertion telescopes through the pulley sleeve to bring it closer to the medial rectus pulley. This distance here is about 7 millimeters. This distance here is about 3.5 millimeters. So basically, the insertion comes closer to the anterior portion of the pulley sleeve. After posterior fixation, you trigger the same lever, this distance does not change. This is from 7 millimeters to 6.9 millimeters. The posterior fixation suture collides with the pulley sleeve and prevents the muscle from telescoping through. So basically, mechanically, it acts as a restriction. You create a restriction to adduction. So if the main effect is not from loss of arc of contact, but the creation of a restriction to adduction, why suture the sclera? This is the logic behind why we created the pulley posterior fixation procedure. In this procedure here, the medial rectus muscle is isolated through a standard approach, and a hook is slid along the surface and rotated anteriorly to hook the anterior portion of the medial rectus pulley sleeve. You pass a suture through that and through the adjacent muscle belly and do the same thing on the superior pole, and you create basically these posterior fixation sutures without any scleral attachment. If you do this procedure here, you actually create the same mechanical effect of posterior fixation without any scleral attachments. Now, we published this finding about 20 years ago, and since that time, it's been shown to be basically equivalent for effect as scleral posterior fixation. The results are durable, and even in a randomized controlled trial in Africa, it was shown to have a significant benefit over augmented recession for certain subtypes of strabismus. Now, how many of you guys in the audience have actually seen a posterior fixation procedure, or you've performed one? Okay. Did you guys suture the sclera, or did you guys suture the pulley directly? Well, the next time you guys think about doing a procedure like this here, I would advise you to check a force reduction before and after you place your suture. And you can verify for yourself that the clinical restriction you see is basically equivalent to the force reduction. If you guys can find that, you can say, okay, well, why would I suture the sclera, which is a much harder and more dangerous procedure for the patient? Once again, something to think about. Now, the next concept I'm going to talk about is the extraocular muscle pulleys. Now, the trochlea is a rigid pulley, been well known for many years here in ophthalmology over. It changes the acting direction of the supraoblique muscle. It makes a hard turn and attached onto the globe here. It turns out that each of the other extraocular muscles also has a connective tissue pulley sleeve. These pulley sleeves are flexible. They're not as rigid as a trochlea, but they do constrain translation of the muscle perpendicular to the field of action. So when you look around, your muscles aren't just flying around your eye socket willy-nilly. They're actually constrained in location here. And that actually simplifies control of eye movements. There also is smooth muscle within these sleeves that can increase or decrease the rigidity and also displace the pulleys perpendicular to the field of action. So there is the implication for active control. If you have muscles, you can control it. Now, this is a series of histological images in a normal adult human subject from basically the orbital apex all the way to the midpoint of the globe. In the posterior part of the orbit behind the globe, it's relatively sparse, just muscle and some fatty tissue. Once you get near the globe itself, though, blue highlights collagen and kind of the pinkish red highlights muscle tissue. You can see that there's these condensations of collagen around the extraocular muscles. It's kind of densest around the medial rectus, then the inferior rectus, and the superior rectus and the lateral rectus. And there's also some bands of some smooth muscle between these different zones over here. It gets quite dense when you get near the equator of the globe. These MRI scans kind of follow that same path over here. These are coronal MRI images. They're not in the true coronal plane, but they're actually perpendicular to the long axis of the orbit. So once again, in the orbital apex, you go further anteriorly over here, relatively sparse. And then when you get near the globe, you can actually see some condensations of the largest of these pulleys. Usually on the medial rectus and this little band between the lateral rectus and the superior rectus, the LRSR band over here. When you look at the position of these muscles, this position is very highly conserved in normal subjects. In other words, if you were to draw a line that bisected the center of the globe horizontally and vertically here, that line would bisect the muscle pass over here. And these positions are conserved within about a standard deviation of 300 microns in all directions in normal subjects. Now, this rather busy diagram kind of highlights our current understanding of the anatomy of the pulley system. So you see there's these bands of connective tissue around each muscle. You can also see that between the medial rectus and superior rectus, there's also some smooth muscle. And these are relatively dense bands, a pretty good coupling between the inferior oblique and the inferior rectus, and then kind of a smaller connection between the lateral rectus and the superior rectus. You also notice here that the muscles themselves are in two tones. It turns out that each extraocular muscle has two layers. Now, why are there two layers? Well, the global layer is the one you guys all know about. That's the one that proceeds through the pulley tissue and attaches onto the globe. That transmits rotational force onto the globe. But there's an orbital layer, and that orbital layer actually stops and inserts onto the pulley tissue itself. And it can shift the pulley along its field of action, just like the muscle moves back and forth. There's some controversy as to whether or not the orbital layer and the global layer have independent innervation, but there's no question that it moves the pulley as well as the muscle forward and back during contraction and helps simplify ocular mechanics. Now, here is a close-up of the medial rectus in an axial scan. You can see the bifurcation of the muscle belly as it approaches the pulley tissue, and part of the muscle inserts onto the pulley. The external part, or the one that's more medial, and the internal part closest to the optic nerve proceeds and starts onto the globe. If you look at it intraoperatively or in a cadaver specimen, you can see the connection between the orbital layer and the global layer just by pulling the insertion anteriorly and retracting the pulley posteriorly. You'll see that these fibers actually connect the two structures over here. Now, here is some histology of the inferior oblique. Just from casual inspection, you can see that the orbital layer has a different appearance. These muscle fibers are different in consistency to the global layer, and they also terminate here into the pulley, whereas the global layer proceeds to attach onto the globe. Now, this video over here shows how when you isolate the insertion on your sutures and you pull it, it does not slide through its pulley sleeve cleanly. It actually retracts the tissue forward and back. That's the connection between the global layer and the orbital layer. Now, this experimental setup here is on a bovine lateral rectus. It allows separation of the compartments, which we'll get to later on here, but also the global layer and the orbital layer. Using this experimental setup and some force transducers, it's possible to coat different parts of the muscle with an impermeable gel and then use calcium chloride to simulate contraction. If you do that, you'll find that the different layers have a different speed of activation and a different force generation. The orbital layer activates first and has a higher velocity of force creation. So what are the clinical implications of the muscle pulleys? Well, obviously, it directly impacts transposition surgery. If you transpose the insertion and do not transpose the pulley, you lose a lot of the effect. And that was the logic behind creating the augmentation for transposition. You actually transpose the insertion, and you actually try to transpose the pulley by using a posterior suture to pull the belly into alignment with the transposition here. It also helps you try to find a lost muscle. Medial rectus is most commonly lost here. You don't want to look into the orbit and along the curvature of the muscle. You want to look towards the pulley position, and that's very surgically located. So it is possible to aid in your location of a lost muscle. It also explains that finding we talked about the entrapped muscle when the muscle is not entrapped. If you have an orbital fracture and the pulley tissue is encased in the fracture, but not the muscle itself, the pulley tissue can act as a leash and a reverse leash as the muscle contracts, because it actually prevents the entire muscle body from moving forward and back. And finally, I believe this actually explains a lot of the exotropic drift found after lateral rectus recession. When you look at the lateral rectus path, it has the longest path in straight head position. It's supposed to wrap around the globe, sort of on the lateral rectus insertion. In an innervated lateral rectus muscle, that path is relatively straight. On the other hand, if you have a lateral rectus palsy, you denervate the muscle, then the path of the muscle can follow along with only the external force that are applied to it, the intact orbital structures. And you see that the path is no longer the straight line, but it actually bows laterally towards the lateral orbital wall. It creates this little kind of hockey stick deformation in the lateral rectus path. What causes that deformation? It's the pulley tissue. The pulley tissue acts as a pretensioner. This diagram here shows the pulley attachments, and they act as a little spring here. So if you have a lateral rectus normal path before any surgery, before any paresis, you'll see that the strength of the muscle, the innervation of the muscle, keeps that path relatively straight. But if you recess the muscle, it actually bows out and pulls out the slack from the muscle belly. Now, this actually depicts it in axial MRI before and after lateral rectus recession. So preoperatively, the right eye here is in the extraocular position here, and you see it has a very straight path from its posterior attachment of the globe back into the apex of the orbit. After about an 8 millimeter recession, you see that the path is now bowed. It actually has increased its path length. When you do the analysis here, we actually looked at subjects before and after lateral rectus recession. The effect was most prominent for large recessions, 7 millimeters or more. And the amount of increase in path length caused by the pulley pulling the lateral rectus out varied between 1 and 4 millimeters, with an average of about 2.4 millimeters. 2.4 millimeters exactly explains a 10 prism diopter exotropic drift after surgery. Now, after we published this finding in 2009, I pretty much abandoned doing large bilateral lateral rectus recessions for exotropia and instead did a lateral rectus recession with a medial rectus resection or plication. And the goal of that is to take up that slack intraoperatively so you will not cause the muscle to bow back. And pretty much my rate of early recurrence of extropia drop down to 0. I pretty much do not see that anymore. So Dr. Clark, why don't you just go ahead and add 2 millimeters to your recession? Wouldn't that take care of the problem? It would if every patient had a 2 millimeter increase in path length. Unfortunately, it's variable between 1 and 4 millimeters. And you can imagine for a 7 millimeter recession, if we reduce the effect by 4 millimeters, you might end up with a significant undercorrection. So if you could predictably say, hey, this is what's going to happen, you can just go ahead and change your surgery. But if you cannot predictably say that, you have to ask yourself, hey, should I be doing these large bilateral lecturous recessions to treat exotropia if the effect is going to be fairly unpredictable? The next topic I'm going to talk about is compartmental innervation. Now, it turns out that each of the extraocular muscles, except for the superior rectus, has 2 neuromuscular compartments. Now, each compartment is capable of independent contraction. And differential contraction has been demonstrated for all the compartments except for the inferior oblique. So it's been demonstrated in the medial rectus, lateral rectus, inferior rectus, and superior oblique. What does this look like? This is a series of histological cross sections through the normal adult lateral rectus. The inferior compartment, inferior branch of the abducens nerve is marked in green, and the superior branch is marked in kind of this pink fuchsia color. If you just trace the branches of the nerve as they go through the muscle, you see that the inferior compartment enters more posteriorly and selectively innervates the inferior half of the muscle with no branches crossing the superior half. And the superior branch enters more anteriorly and does the same thing, innervates the superior half of the muscle with no crossover to the inferior half. The compartmental division tends to be right around 50-50, but it can be up to 60-40, one compartment over the other compartment. It was found in basically every human and primate subject we examined. A similar segregation occurred for the medial rectus muscle. The 2 branches of the oculomotor nerve, the superior branch and the inferior branch, entered the muscle at different locations and innervated only half of the muscle with very little crossover, very little intermingling of innervation. The innervation for the vertical rectus muscles is much more complex. The superior rectus muscle is the only muscle that pretty much has interspersed innervation. There's really no distinct compartments. The inferior rectus has a very large medial compartment, about 60% of the muscle here, and then intermingled innervation for the lateral compartment. Now, using the same type of study we did earlier over here, you can actually selectively innervate the superior compartment, inferior compartment, and the lateral rectus, and you'll see that they have the same muscle properties. These are the same muscle fiber types here, but they're capable of independent contraction, and there's very little adherence, there's very little resistance to having them contract independent of each other. Now, what's the difference between a compartment and a layer? Now, the layers are defined by the anatomy. Part of the muscle inserts onto the pulley tissue, whereas the other part inserts onto the globe. The compartments are defined by the neural anatomy, defined by the nerves. Now, if you try to do functional studies, it's possible to demonstrate differential contractility of different compartments. Now, on the y-axis here, they call it percent change in posterior partial volume. The way you think about muscle contraction is as the muscle contracts, the volume shifts from the anterior part of the muscle into the posterior part of the muscle as it rotates the eye towards the direction of action. So you'll have an increase in the posterior partial volume and a decrease in the anterior partial volume. That gives you an idea, a measure of how much innervation. In this experiment over here, we did what's called asymmetric convergence. Asymmetric convergence means that a target is brought towards one eye and the other eye has to converge to match that target. When you do that, the converging eye, the lateral rectus pretty much relaxes, but the superior compartment has much more contraction than the inferior compartment. So it appears that the superior compartment does more convergence for the medial rectus. This is an experiment done on ocular counterrolling. So basically, if you tilt your head down, the down eye has to encyclotor and the up eye has to excyclotor. The other way goes the other way over here. It turns out that the lateral rectus inferior compartment actually has significant more contraction. It actually contributes to excycler rotation of the up eye. Now, the compartments do have some clinical implications. One implication, of course, is for selective strengthening or weakening of a muscle. You can think about doing a partial tenotomies. For example, if the superior compartment is preferentially the problem child in excess of convergence, why would you weaken the entire muscle? Why not just the superior compartment? Or a slanted recession where one side of the muscle is weakened more than the other side of the muscle. It also raises a possibility for asymmetric pathology. This is a patient with a known abducens neuroma. Now, if you look at the muscle belly, the inferior portion of muscle appears to be more preserved than the superior portion. And if you look at contraction, the inferior portion appears to increase in size during left gaze and decrease in size during right gaze. So it contracts during abduction and relaxes during abduction much more than the superior compartment does. Compare that to the normal side, which both compartments tend to decrease and increase from abduction to adduction. This is what's called a superior compartment lateral rectus palsy. Once we observed this finding, we found it in quite a few other patients over here. These patients are noted to have this asymmetric pathology with a relative preservation of the bottom half of the muscle compared to the top half of the muscle. And these patients do have some significant differences from a complete lateral rectus palsy. They tend to have a smaller primary gaze deviation, and they oftentimes have a superimposed vertical deviation in addition to the esotropia caused by the palsy. So if you see a patient who has a sixth nerve palsy with a small vertical deviation, you should not assume it's maybe a superimposed skew deviation or fourth nerve palsy. It's probably an asymmetric lateral rectus palsy. Now, the anatomy of the superior oblique is unique in many different ways over here. It does have the same type of compartments as the other muscles here, but the compartments are not divided based on a kind of a horizontal or a vertical division. It's kind of more longitudinal, almost like the layers from before. Now, it's long been theorized that the superior oblique has different functions because it has such a broad insertion. This is a cadaver orbit for orientation. This is the front of the eye. This is the trochlea over here. The superior rectus has been reflected anterior to expose the superior oblique insertion. The anterior fibers, marked with the black suture here, attach near the globe's equator. And because they're near the equator, when they contract, there's thought to be more incyclotorsion. And the posterior insertion here, marked with the tan suture, is designed to do more infraduction. So you have two different functions, torsion and vertical duction. And think about the medial and lateral rectus bellies as well here. Now, when the superior oblique is removed from the orbit, as well as its pulley over here, we maintain the same orientation, black suture, tan suture over here. If you cut away the trochlea, it turns out you unroll the superior oblique, it has the same anatomy as the rectus muscles. It actually is not a cylindrical muscle. It is a strap muscle that rolls up, goes to the trochlea, and it unrolls and inserted upon the eye. And if you follow along with the neuromuscular compartments, they actually match the function. The posterior compartment here is innervated by a separate branch to do vertical duction, and the medial compartment aligns with the anterior insertion to do torsion. So the neuroanatomy matches the functional anatomy and gives the same single muscle two different functions. So here is a test where we actually look at vertical fusion. Vertical fusion means you take a normal patient and you induce a small amount of vertical deviation, and usually two prism diopters, and let them fuse it. And you'll notice that the superior oblique has differential contractility. In other words, the medial compartment does more torsion. Now, it turns out in this experiment here, the medial compartment of the inferior rectus does most of the vertical change, and because it induces a excyclotorsion, the superior oblique actually compensates for that, creating incyclotorsion. This also demonstrates differential compartmental contractility. So when you have two different compartments, it also raises the possibility for asymmetric superior oblique pathology. The top series of images, this is a right orbit, left orbit here. The muscles have been kind of outlined here, and these little dashed lines kind of separate putative compartments. Now, you know, superior rectus does not have a compartment. This is kind of segregation we did to kind of measure whether or not one compartment was actually more than the other compartment here. This top series of images, there is no palsy. So this muscle here is basically the same size as this muscle over here, no signs of any paresis. In the middle set of images here, this is basically what we call a complete palsy. A complete palsy is this muscle is significantly smaller than this muscle, but it is kind of symmetrically smaller, a little bit of a ball over here. And this bottom set over here, this is an incomplete palsy in that this muscle is significantly smaller in volume than this muscle over here, but the vertical extent of it has been preserved. In this case here, the implication is that one of the compartments was atrophic, which caused the muscle to shrink in width, but the other compartment is still innervated. And you remember the longitudinal anatomy of the compartments over here. We can't tell which compartment is shrunk, which compartment is actually still intact, but basically this is what's known as uneven atrophy. Now, how can you tell, was it the medial or the lateral compartment, the posterior fibers or the anterior fibers? It's really based on the clinical deviation. If the patient's problem is only a small vertical deviation, but a large torsal deviation, you could assume it's probably the part that's affecting torsion. And it's a more of a vertical deviation versus a small torsal deviation, you assume it's probably more the posterior fibers. Okay. And this also, to me, answers another puzzle I always had was how can one small muscle with a very small nerve create such a variety of pathology, all the way from a very big deviation to a small deviation, a very large head tilt, small head tilt. The reason why is asymmetric pathology. Now, one of the insights of imaging, and a lot of people don't not doing imaging and stuff, is you can determine whether or not the pathology matches the clinical findings. And oftentimes when you do that, you'll find that it does not match the clinical findings. And if you have the pathology set, then it tells you which way to approach the patient. So to summarize the first part of the talk over here, normal biomechanics. Axis of rotation is not the center of the globe. When the eye moves, it rotates and translates. The arc of contact, I do not believe is clinically meaningful. It turns out the part of the arc of contact, which is supposed to have 100% translation of force onto the globe, does not. And the part that's supposed to show a decrease in force application does not show the predicted decrease. So if it does not provide an accurate prediction, it's really not clinically meaningful. The extraocular muscle pulleys simplify neurological control of eye movements. Normal pulley positions help control eye movements. Abnormal pulley positions, we'll get to a little bit later on, destabilize eye movements here. And finally, each extraocular muscle, except for the superior rectus, has 2 compartments. Instead of the 6 extraocular muscles you all learned about in residency, there's actually 11 neuromuscular compartments. Now, this is quite a bit of depth we've gone over here. Of all the things you remember from today's talk here, this is probably the only take-home message I really want you guys to internalize over here. The clinical exam is not diagnostic for pretty much any clinical entity. The clinical exam is descriptive, but it's hard to make a diagnosis. And the reason why is that every pattern of eye movement disorder, whether it's a 3-step test, A pattern, X pattern, V pattern, there's a differential diagnosis of findings that could cause that same type of eye misalignment here. No clinical finding is pathognomonic, even for a 6th nerve palsy. There might be a superimposed vertical. It might be only a partial palsy. Now, the complexity of the system, I think, defies simple clinical rules, simple classifications. That's not my goal to make your life more complicated. It's my goal to introduce probably the next part in our journey in pediatric ophthalmology, and that is artificial intelligence. Artificial intelligence and sophisticated eye tracking here. Now, artificial intelligence is the big buzzword in tech nowadays over here, machine learning. And a lot of ophthalmology is set up for artificial intelligence. We have high quality images of the fundus for ROP and diabetes. We have a lot of functional imaging studies for glaucoma detection. It works very well, except in strabismus. In strabismus, our clinical exam is not that digitized. It's not that standardized. Your 9 positions of gaze are probably not my 9 positions of gaze. Room lighting, target distance, all these things are variables which are not being controlled between different departments. The next step, though, is going to be better data, eye tracking data and automated analysis. This is today's pediatric eye exam. It's kind of clunky, it's very analog, and it's kind of tedious for both practitioner and for the patient. This is the future pediatric eye examination. Okay, what do kids enjoy doing the most? Looking at a screen, watching their favorite video content. Suppose that you had automated eye tracking for high-level precision. Instead of the 9 positions of gaze, you could have literally 1,000 by 1,000 matrix with the eye position found very precisely at each position of gaze. You could incorporate non-invasive measuring of the surface of the cornea, the curvature of the lens, the size of the eye. You can take a fundus photo. You could provide an estimate of visual acuity based on the precision of eye tracking. You could basically have a child sit, watch their favorite content for a few minutes, and then the machine analyzes it and spits out the diagnosis. Okay, you need patching, surgery, whatever you guys need to do, or glasses and so forth over here. This is actually happening all over the world right now. And it's really being pushed not by pediatric ophthalmology, but by the commercial applications of the eye tracking software. And so we'll get more and more sophisticated as time goes on over here. The thing is, we want to feed these machine learning the accurate models of how the eye actually works in order to provide the best estimate for what's going on with each patient. We cannot just use the old approximations. That's not precise enough for the computer-generated simulations. Let's dive into some pathology here. This is a child here who has apparent inferior oblique overaction. I call it apparent because, as you guys know, each set of eye movements can be multiply determined. So if you look at the different gazes over here, so central gaze, not too bad of alignment over here. As the child starts to look towards their right, the left eye starts to elevate. And it does tend to over-elevate compared to the right eye. And it looks down over, it tends to under-depress. So classes would be called inferior oblique overaction and superior oblique underaction. And a similar finding holds for the right eye. Once again, on left gaze, the eye starts to elevate and once again, under-depress. So does this child actually have overacting inferior obliques? Well, the answer is no, does not. This child actually has extraocular torsion of each of the eye sockets. So basically, the lateral rectus is inferior and the medial rectus is superior. Now, how does this pattern of pulley abnormality create the appearance of an inferior oblique overaction, superior oblique underaction? You have to remember which eye is fixating and which eye is following. So for example, as this right eye tracks the target into abduction, the left eye is being blocked by the nose as this occurs over here. The inferiorly displaced lateral rectus is pulling the eye outward, but also downward. The superior rectus has to fire to keep the eye into alignment. From Hering's law, the superior rectus of the other eye also has to fire as well. So what's going to happen to the left eye? It's going to start to elevate as it goes into a deduction. Gives the appearance of inferior oblique overaction, even though the inferior oblique has not had to fire yet. Similarly, the left medial rectus is mildly elevated. As it pulls the eye into adduction, it's going to resist depression of that eye. Gives the impression of superior oblique underaction. And once again, those things appear clinically, but the superior oblique is not underacting, and the inferior oblique is not overacting. This is entirely caused by a muscle positional abnormality. Now here's another child, has a clear esotropy primary gaze, a bit of an A pattern. The eyes turn a little bit more in up gaze, but also come almost nearly straight in down gaze over here. As the right eye tracks laterally into abduction, the left eye moves down, appearance of superior oblique overaction. And then when it looks up, it does not move up very high over here. So this is a patient who appears to have apparent superior oblique overaction, inferior oblique underaction, and also an A pattern strabismus. So what's the abnormality? Well, you guys can probably guess. It's another pulley problem. Okay, this patient actually had incyclotorsion torsion of both orbits. The thing about the incyclotorsion torsion is normally the superior rectus is actually lateral to the inferior rectus. In this case here, it's slightly medial. So when the child looks up, in addition to pulling the eye up, the superior rectus actually pulls the eye inward, creates a larger esotropic upgaze. When the child looks down, the eyes kind of pulled somewhat outward. That gives you basically the A pattern appearance over here. And think about the lateral rectus being elevated and the medial rectus being depressed. Basically, those things create the same kind of problem. As the eyes pulled into abduction, the elevated lateral rectus pulls the eye up and out. The inferior rectus fires to keep it in alignment, creates the other eye to go down. So basically, it creates a pattern of superior oblique overaction, even though superior obliques do not have to fire at all. The next entity I want to talk about is sagging eye syndrome. Now, we first described this in 2013 at UCLA, and it's going to become a bigger and bigger part of your clinical practice. Even if you're not involved in strabismus and pediatric ophthalmology here, it's going to become a bigger part just because the population is getting older. In sagging eye syndrome, the pulleys are displaced by senile degeneration of the orbital connective tissue. Now, if you think about the four main rectus muscles, you have the medial rectus, superior rectus, inferior rectus, and lateral rectus. The medial rectus has a straight shot from the orbital apex to the insertion onto the globe. It also has the largest and stiffest connective tissue pulley. It does not tend to displace from aging. It may be displaced from abnormal rotation of the eye socket, but not from senile degeneration. The inferior rectus is actually supported by the orbital floor. The superior is supported by the globe itself. The lateral rectus is usually the bad actor. It has the longest path, and it has this kind of tenuous suspension from the superior rectus. So the lateral rectus starts to sag, and it does sag normally in all older adults by about 2 millimeters. If it sags too much, it can create a distance esotropia. Now, this is a series of histological signs in normal patients. So from 17 months of age, 4 years of age, 57 years of age, and then of course a much older adult. And anybody who's done surgery, glaucoma surgery, retina surgery, strabismus surgery in older patients, you realize that the Tenon's tissue just kind of melts away. Basically, it's a lot flimsier. This is kind of what happens. This is not in a pathological situation, but just in just normal aging. The tissue melts away here, so the supporting structures of the muscle melt away. But once again, some of the muscles are supported by the globe and other structures. Other lateral rectus is not supported. This series of MRI kind of illustrates the effect pretty well as well. So you look at a young adult, very healthy looking LRSR band. These muscles are symmetrically displayed across the horizontal equator. An older adult, much thinning of the band here, a little bit of a kind of a comma-shaped curve over here, but still relatively well displayed across here. And then even a much older adult, almost pretty much lost at this point over here. And once again, both the histology and these imaging are not done in pathology. They're just done in normal patients who've gotten older over time. And one of the things that also happens when you get older is the muscles tend to become flabby, tend to elongate. I'm an old guy over here, so I say I'm not quite as strong as I was when I was 30 years old. So in the control subject, once again, lateral rectus, medial rectus, these paths are relatively straight. But remember what happened when we had the paretic lateral rectus, we had a lateral rectus after recession. The muscle path kind of bows outward in the region of the pulley over here. This path is now elongated compared to its normal path. Now in this situation over here, this pretensioning of the muscle is not a defect. It does not defeat your surgery. It actually is a benefit because it takes that flabby muscle and it stretches it out. And by stretching it out, it allows it to maintain its strength. That's why most older patients don't develop esotropia, but the muscle is flabbier. And the same kind of thing happens for the vertical rectus muscles as well. So once again, in a control subject, relatively straight paths, superior rectus, inferior rectus. In an older subject, these paths become kind of bowed, but once again, that's not a defect. You're trying to keep those muscles stretched out, keep them strong at the point of innervation. So when would you develop an age-related distance esotropia? Typically, if the muscle path sags down at least a half tendon width below the horizontal midline. So basically a line through the equator of the globe should touch at least each muscle. If it bows more than that, then that's enough of a displacement to cause distance esotropia. Now, why is it only the distance? Well, at near, your eyes are supposed to converge in. As it converges in, the medial rectus contracts and the lateral rectus relaxes. And so since it's supposed to relax, the fact that it's mildly weak does not affect near. So very common history is, I only notice it, Dr. Clark, when I'm driving a car, especially at nighttime, which is a little bit reduced here. The road tends to converge on itself. Look at my computer, look at my device, read my book, I don't see it at all. That's a very common complaint. Now, what happens if the degeneration and displacement is asymmetrical? Then you can get a superimposed vertical deviation. So this patient over here, both muscles are below the horizontal midline here, but the left muscle is much more severely affected than the right muscle. So in this patient here, you would predict that this patient would have either a left hypotropia or a right hypertropia, depending on which eye is the dominant eye over here, because this eye is effectively a depressor in addition to be an abductor. Now, this chart here shows the prevalence of sagging eyes seen at UCLA. Now, UCLA is a tertiary care center, so we're going to see a lot more oddball things than you would in your private practice over here. But already in 2020, the prevalence of sagging eye syndrome was more than fourth nerve palsy, thyroid eye disease, and abducens palsy combined. So in other words, it was the single largest cause of diplopia in older adults, and it was largest others combined over here. Now, in your community-based clinical practice, it's going to be a much higher percentage than that, mainly because you're not going to see the oddball stuff, things like neuromas and other things that you would see in a tertiary care facility. Now, the treatment of sagging eye is still somewhat controversial. Now, small deviations tend to be treated with prisms only, and they do very, very well. I've actually seen small deviations resolve after cataract surgery. Now, why would it resolve? Well, typically the patient is pretty well compensated, even with these muscle positions that are abnormal, just from fusional mechanisms. They get some blurry vision because of a cataract or maybe glaucoma. Now they can't control it, they break down. If you restore clear vision, you can actually restore the fusional mechanism, they can control it with no prisms at all. For large deviations, that requires strabismus surgery. Now, Joe Deemer recommends augmented medial rectus recessions. You have to augment the recessions because you're recessing against a weakened lateral rectus. So it's almost like a paretic muscle. And so you have to do more than your surgical dosage. But it has the benefit of being a surgery that pretty much every ophthalmologist has done. It allows you to do adjustable sutures. There's no refinement technique. I actually tend to like the equatorial myopexy procedure. That procedure, we'll go into later on the talk this afternoon here, but basically you resuspend the muscle with a permanent suture near the equator of the globe, and basically you restore the normal anatomy. And you might need to do a resection just because the muscle pads have bowed out, take up the slack in the muscle. I find my results to be more durable that way. But whenever there's more than one approach recommended for a clinical problem, it's either because no approach works well or every approach works well. In this case here, unfortunately, every approach seems to work pretty well. So you can use either choice here. The next clinical problem I talk about is heavy eye syndrome. Now there's sagging eye and heavy eye. What's the difference? Heavy eye tends to have a lot more esotropia and a lot more severe elevation deficit. Most patients with sagging eye will have a little bit of esotropia in the distance, pretty good alignment near. This patient here has a big problem. So what's the pathology? Here, it's not just sagging of the muscles. There's actually a physical herniation of the globe through the LR-SR band supratemporally here. When the globe herniates through the muscle cone over here, it obviously pushes the lateral rectus inferiorly here, but it also pushes the superior rectus and inferior rectus medially as well. So in addition to the loss of lateral rectus force, now it's almost an effective transposition of the other muscles. And so now you have a pretty big esotropia. And of course, since these muscles are all out of alignment, impaired elevation of the globe as well. Now, if the globe gets really big, this is actually a very large globe after scleral bucket being enlarged here, the posterior muscle blade could actually impinge on the lateral orbital wall. And that can also impinge the eye from rotating inward even further than that. Now, how can you distinguish between heavy eye and sagging eye? In sagging eye, most of the muscle positions are actually in the normal location. Just the lateral rectus is sagging below normal. And so if you draw an angle between the other muscles, you'll see the superior rectus is still in its proper kind of slightly temporal position to the globe over here. In heavy eye, because the eye has herniated supratemporally here, the angle between the lateral rectus and superior in particular has increased. Plus, we can push those muscles apart. And so now that angle is much larger. Now, the treatment for this is actually more unified. You really do have to push the globe back into that space, into the intermuscular column over here by joining together the lateral rectus and suprarectus muscle bellies, either through a permanent silicone band to kind of pull the muscles together or through permanent sutures to kind of zipper the muscles together. There's different techniques described for that. Now, I'm going to conclude my talk by saying that the oculomotor anatomy and physiology are highly complex and nuanced. I don't say this to kind of discourage you, but just give you guys a better appreciation for the fact that a lot of our simple models work okay before the age of artificial intelligence, but really are not going to be adequate going forward. The clinical exam is descriptive and not diagnostic. Things like the three-step test, A and B patterns, infraoblique overaction, those are all terms which you can describe what's happening, but they don't actually predict the underlying physiology of your. Simple clinical rules do not work for many cases. It can work well in some cases, but can just fail spectacular in other cases, which is no result or maybe irreparably fault. And finally, more robust data collection and modeling are necessary to advance the field. All right. Thank you for your attention.
Thank you so much, Dr. Clark, for this wonderful presentation. And we'll open the floor to any questions.
Left you all speechless. That's good or bad. Thanks for staying awake. I didn't see much nodding off.
I have a question about the orbital and global layers.
Okay.
Yeah, how does that change with age?
Turns out it really does not change with age. In other words, the muscles can sag out or sag in as time goes on here, but those relative constituents don't change with age. I've been doing this for a long time, and I found that some of our results to me are very unexpected, which is both good and bad. I mean, the good news is you go into a study, you think, okay, I'm going to find something else, and you find something else entirely here. My mind was completely blown to learn that the superior oblique was actually a rectus muscle in disguise. I was really pretty surprised by that over here. I was also surprised to find that the lateral rectus was actually one of the major extraocular rotators of the globe. Once again, unexpected. So part of trying to do the science behind it over here is to try to look for trends and for behavior that you expect, and then do the experimentation to see whether it actually works that way or not. And we've been surprised more often than we've not been surprised, which I think is pretty interesting.
And for the virtual audience here, Dr. Krapp has a comment.
What's
Hi,
that, sir?
Rob. Can you hear me all right?
I can hear you.
Hi, welcome to Toronto. I apologize. I have a family commitment today, but I'll be seeing you later. So, but I'll be listening in from remote during your talks today. I had a couple of questions. First of all, that was an absolutely superb dissertation on the current state of all the stuff that you've been doing out at UCLA and with colleagues. It's nice to see everything presented in one place. So you're just underscoring something I've been teaching our residents for the last 10, 15 years or longer, that every strabismus entity has a differential diagnosis, mechanical, innervational, orbital. And I think you just presented the arguments so well for why everything really has a differential diagnosis, and you have to analyze a number of things before before you can make a diagnosis. So congratulations on all the work you and Joe and the group have done. I had one question. Something struck me with your discussion about the lateral rectus compartmental issue, where you mentioned that the superior compartment of the lateral rectus activates on induced extorsion when you do a head tilt. Would that not?
That was the inferior compartment. The
Oh,
inferior
is the-
compartment. Yes.
So when you tilt your head, the extorting eye, oh, I thought you had said that it's the superior compartment that turns on. You're saying it's the inferior compartment.
Correct. Inferior compartment.
Okay, well, that I was going to say, because that would support the positive head tilt difference as opposed to just oblique muscle physiology that we've been teaching for a long time, that the head tilt difference is not just an oblique muscle phenomenon, but it may also be a horizontal rectus contribution to the head tilt difference. Is that a correct assumption then?
It is. So here's the graph. We'll do it pretty quickly because once again, these studies are pretty dense here. But you see, it's the inferior compartment of the lateral rectus that contracts for X-cycler torsion.
Okay, thanks for clearing it up. So is that correct then, that our physiology is not, we can't just teach that it's the oblique muscles that are causing the head tilt positivity to the one side, that there's lateral rectus contributions as well?
That is correct. Now, for a clinical practice, this is a little bit of a defect. It'd be nice if every single problem had a same pathology, but an evolutionary benefit is actually a benefit. And the reason why is you want every possible mechanism to be multiply determined. That way, if you had a defect in one, you could compensate for it through other muscles. And so the fact that the horizontal rectus muscles can compensate for torsion is actually a benefit, but it increases the complexity of the system.
Thanks very much.
Michael?
Robert, I thought this was awesome how you summarized 20 to 25 years of work in this, just amazing stuff. I just have a simple question about the MRIs. For a while, we were trying to, when I was at Columbia, getting images like this, but our radiologists could never replicate, making them look like yours. Do you have a protocol or some way to teach radiologists how to do these images?
That's a very nice teaser for my talk this afternoon. We do have a protocol, and I'm happy to share the protocol with you. There's a published paper. We do use surface coils, which are not FDA approved for this purpose. They're actually approved for abdominal stuff. However, we kind of modify them as well over here to enhance the image quality over here. But there is a sequence of steps, how you orient the images, where you do the slices, stuff to get the same kinds of images we have over here. A group in Japan has done a pretty good job replicating some, and also some in Germany as well. But it's not easy. The patients have to be cooperative. I've done the imaging myself. This is one of those human subjects questions. Pretty much everybody who rotates through our fellowship gets the image at some point. Now, is that too much pressure? I don't know. That's called undue influence. It's actually a very tedious procedure. If you image it, you look straight ahead, you look up, you look down. It took me about an hour and a half. And Joe kept saying, "Don't move." Oh, no, I'm not moving. And that kind of stuff over here. So it is a very long procedure for patients. Older patients sometimes have a hard time with it. And so they have to pretty much just try to get the straight ahead position And that gives you, probably 95% of the information you need versus doing the multiple positional stuff. But yes, we do have it. That's a teaser for this afternoon talk.
I had a question about one of the images that you showed with the large lateral rectus recess
Okay.
that eventually ended up well, changing the biomechanics and therefore the drift. My question is it going to change in any way if you use a hangback procedure versus a direct to sclera procedure? Because this looks like it was direct to sclera in this case.
Yeah, all the ones we imaged were direct to sclera attachments, but the
Okay.
effect should be similar to
Mhm.
a hangback suture. And this actually explains to me one of the mysteries I've always had doing a large lateral rectus recession. And you have the patient on the table, you recess the lateral rectus, and physically the muscle is just slack. It's just sitting there. You have to push it further back, even get it back to be 9 or 10 millimeters posterior to the globe. And yet that slack lateral rectus can still pull the eye exotropic after the surgery. So what happens? Well, when they're under anesthesia, both the muscle and the pulley tissue are denervated. When they wake up, the muscle wakes up and it kind of pulls that slack out of the muscle. It's almost the more slack the muscle is, the more it pulls the slack out to kind of restore the normal anatomy. Yeah. So that also explains, how can this muscle be such a bad actor when it's just sitting there flaccid? Can't even push it further back. And that's one of the downsides of a large hangback on the lateral rectus is it just doesn't seem to want to go back any further. And yet the eye can still go exotropic, 6 weeks, 8 weeks, 2 months later.
There's a question from our virtual audience from Jovi, one of our residents. She says, thank you for a wonderful presentation. Are you currently collecting standardized videos of extraocular movements to try and predict the surgical results?
We actually, we had an AI investigator in our lab, but with the current upswing in commercial AI applications, he got hired by a big company. And so we're kind of a little bit stuck on that way over here. Joe and I are both engineers. We're both actually fairly computer savvy. We're not AI experts. And so we're not really, we do have eye tracking stuff incorporated, but we're not at the forefront. I wish we had the ability to retain personnel in this field, but it's going to be a bigger problem because with the salaries going way up for people doing AI in commercial applications, it's going to be hard for us to attract it here. But that is the wave here. At the latest meeting, there was some interesting stuff from Israel and basically trying to predict strabismus, angle of alignment, misalignment, and so forth over here. They're also trying to predict visual acuity based on the precision of eye tracking. And it really works to a very young age and provides a better estimate of the clinical alignment and behavior in young children than you can do in your own exam. If you've done your pediatric rotation, or if you've a clinician, you realize that it's hard to keep their head still, hard to keep their eyes moving and whatnot in the same directions. So it's really kind of an estimate. And this has a potential for a better estimate of that behavior. But we're not really doing it at UCLA. We were doing a bit of it, but now we're a little bit on our heels because of loss of personnel.
Are there any other questions?
Well, I do appreciate your attention, especially people in the very back over there. See, you were me way back in the day over here, so you're probably the brightest of the group. Is that right? That's okay. So thank you guys very much. I guess we get some breakfast now, I think, and maybe finish the registration.
Yeah, so we're going to proceed now to breakfast and registration for Jack Crawford Day. So thank you once again, Dr. Clark, for sharing your expertise with us. We look forward to your second talk during our Jack Crawford Day today.
Thanks very much, guys.
Thanks,
Bye-bye.
everybody.